Hello guys, welcome to the Parson series, and this is part 6 of chapter number 6. So last time we were talking about the myopia along with the degenerative changes. We talked about the spectacles and contact lenses also. So today we will be starting with the surgeries. What are the surgeries that we can do to correct the myopia? And one of the most important is your LASIK, that is laser assisted in situ keratomiliosis. So this is the surgery that is done with the help of a laser. What is a laser? We are using the excimer laser, that is the most popular and widely accepted treatment among all the choices. So the first important thing is that we are using the excimer laser. Surgical correction is only undertaken in individuals 21 years. So prerequisites are very, very important. If you remember, I had given you a separate video on the refractive surgeries. So you can go through that also if you have not taken, because that is very, very important, and especially the prerequisites, because everybody wants to undergo the refractive surgery. There has to be certain prerequisites which has to be followed, because otherwise complication rate is also high. So the person should be 21 years and they should have a stable refractive error for at least 1 year. Who have an unsatisfactory results with the non-surgical treatment, there also we can do, and in whom corneal thinning disorders that lead to curvature myopia like keratoconus have been ruled out. So we have got certain prerequisites, minimum age, then the thickness of the cornea, the stable refraction. We should not have like keratoconus and all these things that can lead to the thinning of cornea. Only then we can undergo this procedure. So let us see the surgical procedures they have mentioned. Now, if you look at the surgical procedure, what is the surgical procedure that we are doing? Actually, we are first raising a flap. So that is the most important part of this laser in situ keratomiliosis. We are raising a flap, and this flap is usually 180 microns. After you raise that flap, the important thing is that it has to be hinged. Okay, don't make it free. So it has to be hinged, and what is left is actually the stromal bed. What is left is a stromal bed. Now there should be some thickness of the stromal bed. It should not be less than 250 microns. So if I say 180 should be the flap, 180 should be the flap, and the stromal bed is also 250, then minimum that you require corneal thickness is 430. So it should be at least 450 microns. So corneal thickness also should be about 450 microns. So when you are raising it, then you have to apply the laser on this stromal bed. In cases of myopia, you have to do the flattening, because I want to decrease the power. So we have to do the flattening of the stromal bed, and you have to keep that flap again back. So that is the basic procedure. If you want to do it in detail, you can refer to the refractive surgery video. The link will be shared in this description box. Now, another method that we can go is the clear lens extraction. Now, what is the basic idea here? Suppose the patient is having an axial myopia, 21 diopters. Okay, its length will be about 31 mm. So the axial length is very, very high. So if the crystalline lens is removed, the parallel rays will be focused on the retina without the intervention of any correcting lens, and the retinal images will be larger than that of the emetropic eye. So that will beautifully solve the purpose. Suppose a person is having high myopia, and that is a axial myopia, maybe about 21 diopters, and the axial length is 31 mm. Then if I am actually removing this lens, then that is clearly solving the problem, because now the rays are focused exactly on the retina without any using of the lens. And also one more advantage that you are getting is that you will get a larger image size, because the main problem that we get with the myopia correction is that the image size is very, very small. Hence the extraction of the lens has been advocated in high myopia, often with immediately satisfactory results. So that is a very quick result kind of a surgery. The operation is however accompanied with considerable danger, because of such eyes withstand with the operative measures badly. But there is a risk that these eyes are very, very thin, because of the so much large size of the eyeball. So mostly they are not able to withstand the surgery well. So that is a great limitation. and the vitreous is also fluid-like, and there is an increased tendency of the retinal detachment due to the degeneration of the retina and choroid. So things are not as easy and as simple as they appear. So though the extraction of the lens is clearly a good way and a good solution, but the surgery itself is a danger to this kind of a eye. Then another thing that we can do is the phakic IOLs. We can also use the phakic IOLs, minus powered concave intraocular lenses designed implanted in the phakic eyes. So instead of giving the concave lenses in the form of spectacles or the contact lenses, we can also implant them in the form of intraocular lenses, and they are either in the posterior chamber fixated in the ciliary sulcus anterior to the normal lens, or they can be the anterior chamber fixated to the iris, or it can be supported in the anterior chamber. So as we can give the intraocular lenses at different places, similarly we can give these phakic intraocular lenses also. You can give it in the posterior chamber. Now because you have the normal lens also, so obviously we cannot give it at the posterior capsule. So what are the other positions? I can give it in the ciliary sulcus, or I can give in the anterior chamber. I can use it as a AC IOL. I can also give it as iris supported IOLs. They can correct the myopia from -5 to -22 diopter, so they are a good option, and we are reserving this only for those patients who are not suitable for the LASIK, and of course the LASIK is considered to be the first choice for the refractive surgery. Now coming to the hypermetropia. Hypermetropia, which is your farsightedness in this dioptric condition of the eye with the accommodation at the rest. So same definition, the parallel rays of light coming from the infinity with accommodation at rest are not focusing exactly on the retina, and here in hypermetropia, they are hyper, so they are going back, so they are going posterior to the retina. So they are going the posterior to the retina. However, by using the power of accommodation, the person can manage to focus the distant objects more easily than the near objects. So this is farsightedness. But always there is a scope in cases of hypermetropia or the farsightedness that the person can compensate for hypermetropia, because he has a thing at his dispersal, and that is accommodation. So some amount of hypermetropia can be compensated by the patient's own accommodative effort. As in myopia, the chief factor here is again axial, that is we have abnormal shortness in the length of the eye. It must be remembered that a small eye is not necessarily hypermetropic, since there may be uniform diminution of all the parts. Now, though they are saying that the axial length is the most important thing which is governing the hypermetropia, same as that of the myopia, but do not take it as a dictum that if the eyes is small, it is always hypermetropic, because if the eyes is small, maybe all the things are also small in proportion, and again the eye will behave as emmetropic. Okay, this is perhaps the most easily understood if the diagrams 5.21 and 5.22 are concerned. So we have already seen these diagrams in the previous chapters. You can refer to the Parson series chapter number 5 for that. If such a diagram is uniformly diminished by the photography, the parallel rays will be still coming to a focus on the retina. So as a matter of fact, highly hypermetropic eyes are almost invariably smaller than the normal. So there are two important things. All eyes which are smaller are not hypermetropic, but all eyes which are hypermetropic are definitely smaller. So the other way is not true. Then the next hypermetropia is a curvature hypermetropia. Curvature hypermetropia means you have got abnormal curvature, so that can occur as a part of astigmatism. It is almost known as a cause of spherical hypermetropia. The only example is the cornea plana. So we can have what you call as a curvature hypermetropia that can be a part of the astigmatism. I can have a problem. So if I have myopia in curvature, then there will be steeper corneas. So similarly, if I have a curvature as a etiology in cases of hypermetropia, then I will have a flatter corneas. So here I can have the cornea plana. Then the second is your index hypermetropia. Index hypermetropia means you have got decrease in the refractive index. Decrease in the refractive index can occur due to the cortical overhydration. If you remember, when we have the cortical cataract, then we have the overhydration, and due to the overhydration, what happens if you compare the refractive index, then what is happening? The nucleus refractive index will be increasing and the cortex refractive index is decreasing. So comparatively there will be hypermetropia. So there it is increased refractive index of the cortex of the lens relative to the nucleus, so that overall refractive power of the crystalline decreases. So when you have the increase in the refractive index of the nucleus per se, I will have the refractive index myopia that will be occurring in the nuclear sclerosis. But if I have the refractive index of the nucleus decreasing with respect to the cortex, then I will have the index hypermetropia. So what is happening, it can be relative decrease or it can be the total decrease. So in cases of the cortical cataract, when you have the overhydration, there is softening of the cortex and there is also decrease in the refractive index. That time also we have the development of hypermetropia. Here in cases they are saying that there is an increased refractive index of the cortex relative to the nucleus. So either you have the decrease in the refractive index of the cortex, or we can say that we have got increase in the refractive index of the cortex related to the nucleus, then also you will have totally decrease in refractive index that will lead to the hypermetropia. Hypermetropia can be classified as low hypermetropia is up to the 2 diopters, moderate is 2.25 to 5 and high is more than 5. So it is very similar to the myopia. And the good thing is that it rarely exceeds 6 to 7 diopters. So this is similar to the simple myopia. Like in simple myopia also it was not going beyond like 6 to 7. So it is same, which is equivalent to 2 mm shortening of the optical axis. Now the individual cases of much higher degrees like up to 24 diopters without any other anomaly have been recorded. Now though usually we do not get much changes and it is usually up to 6 to 7 diopters, but even cases of 24 diopters have been recorded. In the young, the condition may cause no symptoms. If the patient is having hypermetropia at a young age, usually we do not have symptoms because we have accommodation, we can compensate, we have got a good tone of the ciliary muscle, there also we do not have a problem. But when the symptoms are present, they are chiefly referable to the abnormal amount of accommodation to which the eyes are subjected and due to the lack of balance between accommodation and convergence. So usually when the hypermetropia is occurring at a younger age, the problem is not the vision there. The person is able to compensate by the accommodative effort or by the inherent tone of the ciliary muscle. At that time the problem is of the asthenopic symptoms, because the patient is using more of accommodation and there becomes a, you can say, disproportion between the amount of accommodation as well as the convergence. Patient has more of eye strain and all these things. A healthy youth has an ample reserve of accommodation. He can accommodate for the distant as well as near objects without being conscious also. So he is not doing it voluntarily, but involuntary that is being done. If the youth is in poor health or does much near work, there will be overaction of the ciliary muscle and that will produce symptoms that is called as the asthenopia or eye strain. So that is what I was telling you, that these kind of patients usually are not coming with the problems in vision. These people are coming with the eye strain and asthenopia. The symptoms are noticed chiefly after near work, especially when they are working in the artificial light, which is not as strong as the sunlight. So these people will say that we are having eye strain, headache, something uneasy or a discomfort, or we are feeling, you know, annoyed by the strong light, especially after working for long hours of excessive work. That means there is an overaction of the ciliary muscle. They are having more usage of accommodation because involuntary they are compensating for the hypermetropia. The eye aches are there, burns are there, dryness is there, blinking movements are more frequent. Then if you look at the outer aspect of the eye, the conjunctiva and edges of the lids, they become hyperemic. Headaches can be there, especially the frontal headaches. The frontal headaches that are there, most of the times they are due to the eye strain and they feel uncomfortable, they feel some problem when they are doing the excessive work for a longer period. Children with refractive errors may be present with the history of recurrent sty. Now this is again very important. Usually the children who are having the refractive error, they will not come up with the problem of vision. They are coming with recurrent styes, the calision, blepharitis, or due to the increased rubbing with dirty fingers. So here where your clinical acumen works, you should know know that what kind of children are coming, what kind of complaints. So they will not say that we are having refractive errors, and you know, refractive errors are just like the tip of the iceberg. We have so many refractive errors in the society, and refractive errors is the most common cause of low vision, but they are coming up with the problems of infection. They are coming up with the styes, with the chalazion, with the blepharitis, and you will have to see that these people may be having the refractive errors. In young children, hypermetropia may also be a predisposing factor for the convergent squint. Like last time we discussed that in myopia we have a tendency towards the exo. We had a tendency towards a divergent squint. Similarly, in cases of hypermetropia, we have a tendency towards the convergent squint. So these people may also be coming with the ESO. In the latent convergent squint, so if I talk about the esophoria, so if the child is coming, or maybe mother is saying that at times the eye is deviated, I can watch my child when he or she is doing the homework or maybe some near work for long hours, then we can see the deviation. So that is your esophoria, and other forms of heterophoria. All these things are there. We'll be dealing this in detail in the topic of the squint there. In older patients, no symptoms may be present until the power of accommodation is diminished to the extent that near point is beyond that comfortable reading distance, and he or she cannot do the work at that usual distance, you know, or it has to be taken further to see clearly. So in young people, we have this problem of asthenopia because, you know, they are using their ciliary muscles, they are using the tone of ciliary muscle as well as their accommodative effort, and that is causing the strains and all. But older people do not have that problem, so mostly we do not have symptoms. But a limit will come when their you know, near point has receded, so they have to take the things beyond that near point, only then they can visualize. At that time they will start having a problem. Greater the degree, so they are saying that the greater the degree of hypermetropia, sooner this symptom will arise. In other words, apparent presbyopia commences at an earlier age than usual. So what happens, if you have more and more amount of hypermetropia, obviously these problems will come earlier and earlier, and that can also actually present as premature presbyopia. So at times the patient may be coming up with these symptoms. It looks as if there is a presbyopia, and you can make a provisional diagnosis that there is a premature presbyopia, but actually there is nothing called as premature presbyopia, because presbyopia occurs with aging only, and the term presbyopia has been reserved for the aging. So that comes after 40 to 45 years only. So if you are having a condition which is simulating the premature presbyopia, always make sure that you rule out the hypermetropia as well as the open angle glaucoma. As far as the fundus, now, as far as the fundus is concerned, in the hypermetropia, it is normal on ophthalmoscopy, but a bright shining reflex is seen of the optic disc, that is called as the pseudopapillitis, or the silk short appearance, that is called as the silk short appearance, or it is also called as the pseudopapillitis. It is also called as the pseudopapillitis. In comparison to the emmetropic eyes and in comparison to the myopic eyes, the eyes are very, very bright, and in some cases it can be due to the smaller optic nerve head. So what I told you, this condition is called as a pseudopapillitis, a very bright shining reflex is seen. Anatomically, if I talk, the smallness of the eyes affects the entire eye. The diameter of the cornea is often reduced, and regular astigmatism is common. If I talk about the anterior chamber, so obviously we have got smaller eyes, anterior chamber is shallower than the usual, and why it is happening? Because the eyeball is smaller but the lens is normal. So there will be occlusion obviously. So the normal lens is occluding that area, and that is why we have more propensity towards the angle closure glaucoma. Newborns are invariably hypermetropic. This we already know, about 2 to 3 diopters of hypermetropia is present in the newborns. In the first decade, the incidence of hypermetropia falls rapidly, and it is going to 50% after 20 years. So every child is hypermetropic at the time of birth. Slowly and gradually there is emmetropization. By 5 to 7 years, the eye becomes emmetropic. The incidence becomes less than 50% after 20 years. There is no predilection for the sex, and it is interesting that the primitive races in the higher mammals, especially carnivores, are also general hypermetropes. So that gives you, some clue that evolution is taking place. All right. So this was about the hypermetropia. We have talked about the myopia and myopic treatment, as well as about the hypermetropia. In the next session, we will be dealing with the other refractive errors along with the treatment of hypermetropia. Till then, keep on reading ophthalmology, keep on reading Parsons. Please update all the things according to your Parsons series. Goodbye and happy ophthalmology.